This week we'll be discussing economic analyses. And economic analyses are, I wouldn't say fairly new, but they're not typically what is seen in rehabilitation and in occupational therapy research studies, but they are becoming more common. Typically, if you're running an economic analysis in a study, you would engage somebody who has more understanding of economic factors and how to run an analysis. So, if you're doing a study as an occupational therapist, you would typically have someone on board who knows more about these types of analyses. But from the perspective of being a student in occupational therapy and getting a doctorate, it's important to be able to read the studies and to understand a little bit about what economic analyses mean. Mostly in rehabilitation outcomes, we ask, does something work? Does it make a clinically significant difference? What's the evidence? But we also ask, what's the value? What is the cost? Is something that someone is doing worth the cost? Are there less costly outcomes? And what is the risk? Ideally, we're looking at something that would give us maximal benefit for minimal cost and minimal risk. The types of economic evaluations, and that's gone over more in depth in your textbook, are cost consequence, cost minimization, cost effectiveness, cost utility, and cost benefit. And we'll be going through these briefly to define them and to talk about an example, a brief example of each of these, because they are different, and but there is overlap often in a study. Cost consequence evaluations are detailed descriptions of the costs and the outcomes of a health service that someone may be receiving. For example, in the Duke 2005 article, the author looked at the costs and outcomes of frail, elderly, community-based case management programs. So what are the costs and what are the outcomes? And the outcomes that they looked at were hospitalization, emergency room visits, and length of stay. So knowing about these types of outcomes gets you to think about what are the kinds of cost outcomes that one can look at. So is somebody need to go back into the hospital? Do they need to visit the emergency room more frequently? And when they go in the hospital, what is their length of stay? So the study was evaluating whether case management programs for frail elderly make a difference in these areas. But the study was really more of a description of what the costs and what the outcomes were. Cost minimization analyses identify the least costly alternative when two or more services produce equivalent outcomes. And in those type of studies, they need to determine equivalent outcomes. So the outcomes for one group are the same for another. And the Jones et al. Study looked at people receiving hospitalizations at home, and they stayed at home rather than going into an acute care hospital. And they had similar outcomes at the end of their stay, and the authors wanted to see if there was a cost differential. And what they found were that costs at home were similar or lower for an acute care hospital admission. So if someone was able to stay at home and receive services at home, it could be, depending upon what was needed, it could be similar or lower costs. Cost effectiveness studies, and that's what we think of mostly with the terminology, even though the more I'm reading, the more I learn about economic evaluations. We often talk about cost effectiveness, but we may mean something else, but we often call them cost effectiveness studies. They describe and compare the relative costs and the outcomes of two or more services. So, do they, what happens at the end? What are the outcomes? And then, what are the costs? And in the Bendixson, Levy, Olive, Cobb, and Mann study in 2009, telerehabilitation was compared to the control group for usual care, and this was for veterans with multiple comorbidities and functional deficits. So these were veterans who had many health problems and functional deficits, and to see if telerehabilitation had different outcomes to the usual care and different costs for usual care. So there were costs because of the type of program that the telerehabilitation provided. There were costs for the provision of the adaptive equipment and environmental modifications. There were also costs for in-home monitoring, and there were increased clinic visits as compared to the hospital and nursing home stays. And what the authors found were that there were no significant differences in costs between the groups. Cost utility, another form of economic analysis, compares the costs and outcomes for two or more services that produce different types of outcomes. Cost utility considers health status and the value of that status to the clients when outcomes are being compared. So in the Patel et al. Study, for those with stroke, domiciliary care, where people who had had a stroke were managed in their own home, was less expensive than care in a stroke unit. But on the other hand, when another measure of outcome, which is the per quality adjusted life year, was included. So, what is the quality of your life over the lifespan? The stroke unit was more beneficial than being managed in their own home. So, it was not only the expense. Economic analyses don't always look just at the cost or the expense, but they also may look at what is the quality adjusted life year. So what is the quality of that person's life? And finally, we have cost benefits. And cost benefit analyses assess the monetary value of outcomes. So one study, Margolis and Petty in 1994, and I want to do an aside, that I'm not that familiar with this body of knowledge, so I don't know, because it was a 1994 study, I don't know if things have changed, because I am somewhat familiar with mental health, for children's mental health, so I'm not sure if this type of study changed. I'm just sort of providing the outcome, just to give an example of the type of analysis, because when you look at cost benefit, what I was finding is that many of these studies say cost benefit, but they don't often provide a cost benefit. They compared home-based services to increased remuneration or payment for out-of-home placement to potentially decrease the length of stay in a children's psychiatric hospital. So they compared services provided in a child's home to increase payment to providing out-of-home placement, and the ultimate goal was to decrease the length of stay in a children's psychiatric hospital. When they analyzed the cost-benefit for the intensive home-based services, it provided a favorable cost-benefit ratio of 0.47. When they analyzed the increased payment for community-based payment, however, it resulted in a cost benefit of 1, indicating that there were no financial savings for this particular service to decrease length of stay in a children's psychiatric hospital. And now I want to change gears a little bit to look at, this is to look at your handout, one of the handouts, the handout that you have for this week. And this is a recent publication. You can also, besides having a PDF, you can also, it is on the web in the AOTA website. And this was a project done by Heather Parsons, who is the Director of Legislative Advocacy at AOTA, in conjunction with Elizabeth Hart, who was a fieldwork student at AOTA when she was getting her master's. And the project was to look at what's the evidence out there for cost effectiveness or cost in general. And that's where I say, knowing about the cost effectiveness, we often say cost effectiveness, but it may not always be specifically a cost effectiveness study, is to look at what's the evidence for occupational therapy for the outcome being cost. And they looked at the evidence. Elizabeth reviewed the evidence, and this is a really important handout to read because it is something that you will be able to use in your practice, in occupational therapy practice, over and over and over again. As you talk with people about the distinct value of occupational therapy, you can also use the evidence to say, not only do we have distinct value and do we make a difference, but we also can reduce costs. But as I said in the beginning, there is limited evidence in this area, and Elizabeth really found the latest, and she went back to see what is the evidence in this area. And what you can see is that there was evidence in age-related decline, and that there was, from the well elderly study, you can see that there was that it can maximize independence and enhance functioning, and that well elderly study was also been shown to lead to healthcare savings that exceed the intervention's modest cost. Also, you will see cost savings in the area of fall prevention, Alzheimer's disease, chronic pain. And the conclusion of the document is that occupational therapy has a distinct role in, and this was focused mostly on primary care, in new primary care health delivery systems that focus less on specific diagnoses and more on preventing illness. And as demonstrated, OT interventions can not only reduce costs, but can improve overall health, quality of life, and daily participation of individuals and their caregivers. So as you go through your training, think about how you might want, and you're thinking about research, probably not for your doctoral program, but for the future. How can you incorporate some cost benefit? How can you bring in, because as I mentioned earlier, this is not something that you would do as an occupational therapist, is to evaluate the cost, but to bring in somebody either in public health who focuses on cost effectiveness and cost studies, or someone in economics who focuses on healthcare. How can you bring someone in to focus, to evaluate the outcomes as they relate to cost. And finally, these are the references that were used and they for today's PowerPoint. And thank you. Have a great week.